Welcome to today's UEFA medical webinar. Another one in our build-up to the Women's Euro series about the female player. Last time. Today we're going to talk about menstrual pain management. We got a beautiful lineup of a lot of people on our panel. They will join us later. We got Mike Harrison from Chelsea FC. We got Floor Sijbrandij from UMC Utrecht, and we got Emma Paternotte, also from the Netherlands. And they will help us later with a lively discussion on the topic. But first up, we got Preeti Kachroo from Haleon, and she's going to get us through some of the background of this topic. Before we kick off, I would like to highlight that this webinar is also supported by the European Clubs Association. So if you represent a club, please let us know in the comments box, so we also know who we have online today. Late in the live discussion, you are, as usual, invited to put your posts and your questions in the comment box. If you do so, given the topic, it's likely that maybe you want to discuss something that happens to you in your club. Please make sure you do not share any details of a player or a patient, so that is not traceable to anyone. Keep your questions as broad and general as possible, please. Just to avoid that. So, Betty, can I invite you to the stage? Yes, there you are.
Thank you so much. It is such a pleasure. Can you hear me?
I can hear you very well.
Thank you so much. I'm just looking forward for sharing the insights in menstrual pain management. And can I have the slides, please?
Yes, your slides will come. And then I'm off, and the screen is yours, Betty, and we'll see you all in a bit.
Thank you so much. Let me take all of you, embrace yourself into a journey. You may have already known about it, but we will take up few areas that can help you in terms of what is the diagnosis, what is the management, and of course the honorable panel that we already have that I would mention can help you further in terms of the panel discussion and to bring in their own real world experiences in how you're going to manage. Let's move forward and let's talk about why are we here and why are we talking about period pain here. So I have picked up some of the quotes that are very close to me. One of them is from Michelle, where she talks about, we need to see periods as a superpower we can tap into to optimize how female athletes fuel, recover, and ultimately perform on the pitch. So it's very important to know thyself. It's very important to understand and then to manage and then to perform. So here we will take a quick overview into dysmenorrhea. As we know, it's the painful monthly bleeding as it used to be known in the Greek term. It's typically described as a cramping pain in the lower abdomen, beginning at the onset of menstrual flow, usually lasts 12 to 72 hours, and the number of days also varies from individual to individual. And when we talk about the areas of pain, it's usually in the lower abdomen. It may radiate to inner thighs and back. There are some accompanied other indications as well, like there is nausea, vomiting, diarrhea. Some people even end up with headache, even migraine, muscle cramps, and low back pain. So there is a lot of fatigue and some sleep disturbances, again, depending on individual to your individual patients. Now let's look into what are the risk factors. Age which is younger than 30 years, high or lower than normal body mass index, smoking, depression, earlier menarche, or longer menstrual cycle. Even heavy menstrual flow is also one of the risk factors when we talk about dysmenorrhea. Let's look into the prevalence. Why is this prevalence important? Whenever we think about a population, the patient population, it's very important to understand the severity, the incidence, and the prevalence because it helps to understand why we require attention on the diagnosis, why we require awareness around it, and how it should be managed and managed well. So when we look into dysmenorrhea or the period pain is one of the most common gynecological concerns among all menstruating patients, regardless of age or race. And it not only affects up to 90% of adolescent girls and women of reproductive age, there are stats that 3 out of 5 women who are suffering from period pain, they do not even report the menstrual pain, or they do not even talk about their period pains. There has been this systemic review and meta-analysis of the studies where 20,000 young women were evaluated across 38 countries, and the prevalence of dysmenorrhea was seen around 71%. Imagine the number of percentage that it is impacting. And the greater prevalence is seen, usually reported by younger women, which is less than 24 years. There are other factors which may impact at certain age where the prevalence decreases, for example, after pregnancy and use of oral contraceptives. However, again, it is patient to patient variation in terms of how much is the patient threshold of the pain that the patient suffers. Now, what is key impact of these patients? So one of the impact, it's not only about the pain, it's also about the quality of life. And the quality of life not only leads to absenteeism, that means one half of the patients with dysmenorrhea, they not only miss school, they also miss work. So there are 10 to 15% that have regular absenteeism just because of dysmenorrhea, just because of their menses. Now, in United States alone, dysmenorrhea is estimated to be causing roughly 140 million working hours per year. So when we look into the stats, so that means there is this socioeconomic impact as well, which is the socioeconomic burden on the countries when we talk about period pain and the associated impact, not only on the quality of life, but also on the economical part of it. Now, when we look into the dysmenorrhea, then you see that there is a limit of patients' participation in sports or social events. There was one of the quote in his paper, by the Chinese athlete, which mentioned that her performance was impacted because of the period pain. So there are these impacts which not only have the psychological or functional, or as well as the physical impact in your day-to-day life, especially during these monthly times. Some of the patients also have associated depression, anxiety, stress-related disorders, and even in their social life, in their relationships, they have a negative impact because of their regular menses. When we look into the life course potential beginning in adolescence, there is a clear hindrance, not only because of the attainment of the career aspirations, social relationships, also for the emotional well-being, or even starting a family or having any relationships. So let's look into a bit into these impact of dysmenorrhea on the life course potential. Some of it I covered already. So there are these other impacts when we look from the life course potential, whether it is the romantic relationships, family goals, mental health, even education and career goals that are impacted when we talk about dysmenorrhea. So there are different aspects that are revolving around the period pain that needs to be addressed, that needs to be looked into when we think about this situation. Let's go to the types of dysmenorrhea. So primary and secondary are the two dysmenorrheas that we will briefly cover. And then there is Dr. Flo, Dr. Mike, who can also take you through a bit on their experiences in terms of not only the diagnosis, but also the type of managements, which we'll be covering. So a little overview on primary dysmenorrhea. A quick recap, as I mentioned earlier, it is a recurrent lower abdominal pain that happens during the menstrual pain and is not associated with other diseases or underlying pathology. And a bit of reflection, Dr. Floor will share from her experiences that there are some conditions which are also associated when we talk about the primary dysmenorrhea, which is related to the urinary. Now, irritability, headache, lower back pain, which is very much prevalent when we again talk about primary dysmenorrhea. And majority of cases of dysmenorrhea are often identified in adolescent and young adults. The pain is located usually midline in the pelvis, and it may radiate into the lumbar area of the back or the upper legs. And the cyclic pain starts within a few years at the onset of menses. So menarche is a very important differential factor when we talk about primary to secondary dysmenorrhea, and it usually resolves within 72 hours. And again, it is very different from patient to patient. There are some exceptions where the pain may last continuously for more than 72 hours as well, but this is the stats coming from the published literature on an average how this responds. When we look into the mechanism of action, there is hormone-dependent prostaglandin, which is known as PG pathway, that causes intense uterine contractions, which leads to decreased blood flow and increased peripheral nerve hypersensitivity, resulting in pain. A bit on the mechanism of action we will see in the later part of the slides as well. And as I mentioned, initial onset begins about 2 years following menarche and corresponds to the initiation of the ovulatory cycles and tends to recur with every menstrual cycle. Now, let's go to the pathophysiology, which I briefly have mentioned before, and I think we already spoke about the progesterone. And then when we look into this endometrial inflammation, this prostaglandins, it may be because of the genetic predisposition, it may be because of the myometrial events, and either ways, it leads back to dysmenorrhea, which we are discussing today. Let's go quickly a short overview on secondary dysmenorrhea. It occurs due to clinically identified pathology or a recognized medical condition, and most common is the endometriosis. It accounts to around 10% of the cases of dysmenorrhea, and it can be congenital, it can be obstructive, non-obstructive, anatomical abnormalities, and there are various other reasons like pelvic masses and infections. Usually onset it may affect at any time after menarche, but usually it is at a later stage of the patient or the women, I should say. And it can be a new symptom for females in their 30s or 40s, which is you have already started menarche a little early, around 12, 13 years, and then around 30 years, you will have this secondary dysmenorrhea in most of the cases, but again, not limited to. Symptoms may include progressive worsening of pelvic pain, abnormal uterine bleeding, vaginal discharge, and another important part is dyspareunia, which may be associated with secondary dysmenorrhea. Another important quote that I really like, which is by Emma, I think is here. The starting point is that we are women, and ultimately we go through something very different to men on a monthly basis. And I think we have Emma here as well. So I think it's like resonating on the same, that we are biologically different. So we have to remember this part. And I think the people around us have to remember this part as well. Whether we are in sport or we are in work or we are in any other area. So we have to manage the gender differently, and we have to address the indication, and we have to address it more appropriately and timely. About the diagnosis of primary dysmenorrhea, if you see, the symptoms could be, because of many patients assume pain is a normal part of menstruation, so they may come very late in terms of diagnosis, or they may be shy. There is social stigma. There are many factors where either it is not being shared, or there is less awareness about it, or it is elucidated that it comes as a normal part of the menstruation, so I have to live with it. So there are many reasons how sometimes the diagnosis get difficult when we talk about the primary dysmenorrhea. Again, evaluation includes complete medical, gynecological, and menstrual, family, and surgical history. A history can include location of the pain, timing of onset, characteristics, because they may be coming very late defining their period pain. They must have been suffering for quite some time. And it can be associated with the factors that I mentioned earlier, like fatigue and headache. And it may be diagnosed based on the typical history alone. So pain begins just before or start of the menstrual bleeding. And this is cyclic, and it begins with the onset of ovulatory cycles, as I mentioned earlier, and the pain peaks at 23 to 48 hours. So sometimes if it peaks and it drops down, so they feel, okay, it's a normal part of the routine, it's okay, it comes monthly, and they normalize it so much they don't even come to the medical advice on that. So lack of abnormal discharge, adnexal masses, and are the typical findings in the primary dysmenorrhea. The pelvic examination is not necessary in patients presenting with symptoms consistent with primary dysmenorrhea. Remember, these are coming from the published literature, but we already have our two gynecologists here, and we already have our HCP here. So I think it will be good to hear from their clinicians' experience what works well when you are in the clinical setting. Secondary dysmenorrhea, the common findings that may indicate are older age, vaginal discharge that is whitish gray, mucopurulent, or it has a foul disorder, and then friable cervix, dysuria, dyspareunia. There can be heavy menstrual bleeding that I mentioned earlier, and there can be abnormal bleeding with enlarged asymmetrical uterus, and it can be obstructive anatomical abnormalities. Now let's go quickly into the differential diagnosis. Remember, we spoke about few of the factors there. So endometriosis, ovarian cyst, uterine polyps, and then it can be adenomyosis, and then it can be even congenital obstructive Mullerian malformation. So there are various diagnoses associated with secondary dysmenorrhea and not limited to. However, there is a differential diagnosis how you can identify that it may be this characteristic or signs and symptoms that can help you differentiate between what is the cause for this secondary dysmenorrhea. So if it is a heavy bleeding and with blood clots, pain with intercourse, so it may be adenomyosis. If it is just infertility, urination, bowel movement, it may be due to endometriosis. So there are different factors which may impact and help you in identifying the root cause. So I'm picking up another quote from Carroll. It has not been demonstrated that menstruations would result in a performance decrease for a female athlete. Very important point. Except if she suffers from disorders during her menstrual cycle, namely a painful period. It doesn't mean that athletes, or it doesn't mean that women are incapable. It's just that the management of that specific painful period has to be done very timely for them to perform and to deliver their best. So looking into starting from the NSAIDs as the first line therapy for primary dysmenorrhea, providing more than 80% of sustained release responses, and up to 20% of patients report minimal or no relief. Ibuprofen, naproxen, ketoprofen, mefenamic acid, and nimesulide are all superior to placebo. But when we talk about OTC, mainly the molecules that are being picked up off the shelf are like ibuprofen and naproxen, which are primarily being used. Diclofenac is also there, but it has associated some risk factors. Ketoprofen is not sometimes widely available. And then again, there are mefenamic acid and others, which are again the choices or sometimes are prescriptions, so can't be picked up over the counter. So mechanism of action, I think we will not go into details. It is by reducing prostaglandin that we spoke earlier in terms of how it settles down. The reasons for lack of relief from NSAIDs can be they are not either taking the right dosage. So that means the dosage and the duration are very important pieces when we talk about the management. And it may be because of the variance in menstrual cycle, which may prevent the appropriate timing of treatment. And at what time are they taking? Are they taking it at during their menstruation period? They are taking early. So how is the treatment being managed? And are they taking the effective recommended dose or not? Similarly, there are some non-NSAIDs as well, like paracetamol and caffeine. While paracetamol is already mentioned as effective treatment for key menstrual symptoms of pain and abdominal cramping. However, when you have caffeine with paracetamol, the caffeine provides that adjuvancy for efficacy. So it is a preferred option when we are talking about NSAIDs from paracetamol versus paracetamol caffeine for the superior and analgesic efficacy. Let's move to another key area. I think this is another very important area because hormonal therapy is considered a first-line treatment of dysmenorrhea. And when we talk about the dosage, it's convenient, one tablet, and again, depends on which combination that you are taking. And it can be added or can be used as an alternative to NSAID therapy in patients who are not planning to become pregnant. So again, combined estrogen and progestin oral contraceptives are effective in adolescents and adults with primary dysmenorrhea, leading to significant improvement in pain and decreased frequency and dose of analgesics. So we will hear more from the clinical experience from Dr. Floor and Mike in terms of how it has been managed and what are the preferred therapies and what is the kind of dosage, a bit in terms of the mechanism for hormonal therapy, a combination of estrogen and progesterone contraceptive limit, endometrial growth, as well as inhibit ovulation. So we spoke about progesterone earlier. Now we are adding up another layer to that. We are talking about the endometrial growth and the inhibition of ovulation. So that's how the hormonal therapy brings in additional benefit here. So over time, as the endometrium thins, menses becomes lighter and fewer uterine contractions occurs with menses. So there is a relief from pain, and this in turn decreases the PG production as well. However, remember, I think the bottom of the slide, you must have seen that there are associated adverse effects with all these therapies and management that we are mentioning. But as long as you take it within the recommended dose in major population, it supports and it benefits them. Non-pharmacological treatment, I think some of us know already. There are many of them. There is physical activity, there is stents, there is acupressure, there is acupuncture. Then there is even as simple as local application of heat, and it can be even using a simple hot water bag, or it can be some heat patches, or it can be some medicated patches as well, and some herbal diet patches that you can put, and some dietary supplements. So it's a combination of multiple things we see nowadays. It is more tailored approach how the patients are being managed. And sometimes it's not limited to only pharmacological, so there are these non-pharmacological treatments as well, which play a key role in how effectively we can holistically manage the patients. Now, a quick look into the other treatment options. There is aromatase inhibitors, there are calcium channel blockers, there are antispasmodics. So the market is flooded with hyoscine, butyl bromide combinations, either as alone or with paracetamol. And due to their anticholinergic effects on muscarinic receptors, they result in smooth muscle relaxation, and it has been used a lot. But there is some recent data where this hyoscine, butyl bromide or antispasmodics are not preferred, either are considered ineffective or are associated with other adverse events. So it's very much patient to patient approach by HCP or over the counter, which molecule is best suited for you, and which is best suited for the patients, and how it can help in terms of their pain journey. There are even products like magnesium products, which are helping in the muscle relaxing effects and vasodilator properties, again bringing it back in terms of easing out the pain. There are surgical options as well: laparoscopy, hysterectomy, and endometrial ablation, and it should only be considered used if there is no satisfactory response to the trial of medical management. Very important point. Now, quick recap on for the management of dysmenorrhea. More or less, we have covered a bit on it. So a quick recap on this one. You can say the history is consistent with the primary dysmenorrhea. So you go ahead, initiate the empiric therapy, can start for 3 months with the NSAIDs, and then if there is an improvement, continue the therapy. No improvement, assess for the treatment adherence. And again, after 3 months, if there is no improvement, then you go back to the option A. And if the history is not consistent with the primary dysmenorrhea, you evaluate the symptoms of secondary dysmenorrhea, perform pelvic examination, and then with the normal findings, refer to the OBS or gynae, and with abnormal findings, treat identified for the abnormalities. So now let's quickly go into the treatment recommendations. There is empiric therapy that should be initiated, that I mentioned earlier. The NSAID we already spoke about. Paracetamol and the combination like with caffeine or antispasmodic that we have mentioned. There is some data around it for the visceral pain. Combined therapies, we spoke about hormones and then estrogen and progestin, oral contraceptives. And then you can consider exercise, high frequency transcutaneous electrical nerve stimulation, also known as TENS. There are a lot many TENS devices which you can put on the lower abdomen that are available not only over the counter but also on Amazon and other areas. So it can provide some relief, and also heat therapy is self-acupuncture. So up to 70% of adolescents who do not respond to the first-line treatment have been demonstrated to have evidence of endometriosis on laparoscopy. So prevention, a quick quote here: what chance are we giving to girls and women as they lose days of productivity every month due to their menstruation? So kind of a reflection that what we need to do, what we need to reflect, and why this area for awareness is important. So balanced, healthy nutrition and regular exercise to reduce the severity of dysmenorrhea. The patient should consider, regarding the treatment options for dysmenorrhea as well as potential complications associated with secondary dysmenorrhea. We should also look into how it's not only the nutrition, it is also the lifestyle, the physical activity that needs to be considered, and the exercise specifically that acts as a non-specific analgesic by improving pelvic circulation. So some mild exercises are good. And early recognition of dysmenorrhea. So if there is less awareness, so maybe we can have some educational areas where we can cover in terms of how this can be identified or it can be reported well. And there is a recognized need to improve education to the general public, healthcare providers. Healthcare providers play a very important role, not only bringing it forth, but also bringing awareness around it, and not only about the hygiene, but also about period pain and associated menstrual health. So the conclusions, I will wrap up here. Dysmenorrhea is one of the most common, as I mentioned, gynecological concerns. So that means we really need to pay attention to this. And hormone-dependent prostaglandin pathway causes intense uterine contractions. So that means we need to have the management well, which can adjust to this pathway. Symptoms carefully elucidate that, because many patients assume pain is a normal part of menstruation. So normalization may or may not be good for the patient. So we really need to bring more awareness and more reporting towards this. And again, like NSAIDs, hormonal therapies, non-NSAIDs like paracetamol or combinations or antispasmodics, and some non-pharmacological treatment, I think it can give you the alternatives when the first-line interventions are contradicted or declined. So that can be another option for you to go. And of course, if none of these interventions work, we know that there are the surgical interventions that I mentioned earlier. So that should be all from my side. And I think I will pass it over for the open panel discussion to bring the expertise in and to learn more on the journey.
Thank you, Preeti. That was a really comprehensive yet clear overview of today's topic from A to Z, I think. And enough questions I scribbled down here that we can use in the discussion. May I introduce to you all the other panel members? We have Mike Harrison from Chelsea FC, Emma Paternotte from the Netherlands, and Floor Sijbrandij, also from the Netherlands. So we have a vast amount of football experience here on the screen, gynaecological experience on the screen, so we can go anyway with the questions. And maybe to start it off, we're talking about dysmenorrhea here. How often do you encounter this issue in football players specifically, and maybe in relation to a general population? Mike, can I start off with you, because
yeah, absolutely. Thanks, Pretty very good and very clear. And but yeah, no, thanks. I think this is a daily occurrence in female team sport and within our football team at Chelsea. I think it's something I encounter every day, and something that the players are used to inquiring about, asking about, and I think so I think they know and expect that they can get it treated and sorted, and whether that's medication or whether that's support through exercises and or using a TENS machine or hot water bottle. I think it's part of the sort of day-to-day process of working within a female team. So it would very much be. It's not all the players. Most of the players, maybe half of them, you don't see too much of, but the other half probably, during their cycle will come to see you at some point and raise this as a symptom.
Got it. And Flo and Emma, in your experience, I guess this is a problem for any athlete, for any individual. Is it a bigger problem for football players, or would you say?
I actually think it's a problem for all the female athletes. And of course, when they come to us as a gynecologist, they always have symptoms. So for me, it's very hard to say how many % of the athlete females have dysmenorrhea. But we know also in the general population that a lot of female have dysmenorrhea. And I think it's very good that you have this open panel discussion, and because I think it's very good if we are all more open about it and have more opportunities for conversation, because it is not normal for a female athlete, or actually for a female, to have a lot of pain during your period. So I think also what Preeti told us about the primary and secondary dysmenorrhea, you had a very nice overview. And for us, actually, the most important difference is the timing of onset. So the primary dysmenorrhea typically starts shortly after menarche, the first time you have your period, and the secondary dysmenorrhea develops later in life. And most of the time, the secondary dysmenorrhea have different underlying causes like endometriosis, adenomyosis, etc. But for us, severe menstrual pain is not normal, even if it's primary or secondary dysmenorrhea. It doesn't matter. I think you need to be referred to a gynecologist to make sure what's wrong, and we can try to help you. And also, because that's also what we see a lot in our outpatient clinic, that there is a patient delay or a doctor's delay if young girls have primary dysmenorrhea, because they think, oh, but I think it's normal to have pain. But sometimes if you have a lot of pain for the first time, there can also be uterine anomaly or an hymen imperforatus or like another problem. So I think for you as coaches, if it's possible to be open about it and talk to your athlete, I think that's actually the most important step. And then if you also remember that it's not normal to have a lot of pain, I think then we are already very happy as a medical team.
Because some questions pop up in my mind and you immediately answered them, I think, in your answer. If this is such a common issue, is that non-normalization one of the main reasons it's still underreported and undertreated in athletes?
I think so. Yes, I think so. Definitely. Because we as a young girl, you don't know what is normal. And you know, a lot of people who are talking about, oh, I have abdominal pain because I have my period. But then you don't know what is normal. And I also see that, especially with the elite football players and elite sport ladies, they are used to a lot of pain. So when they have pain, they actually think it's normal, or I can handle it because I'm used to pain. But if that's a reason why they cannot go to training or to practices, I think you need to help them. And indeed, what Preeti said already, you have different treatment options. We can talk about that later. But the first most important topic, I think, is address it. Talk about it with your players.
And if I can add up to 2 more points that is coming from the published literature as well, that there are 3 pointers. One is the lack of awareness. The second is social stigma, which plays a huge role, let's say, because I hail from Asia Pacific. So I know in certain parts of Asia Pacific, even talking about is, they are so shy, it is more like a taboo, even talking about it, even if they are athletes or even if they are, working, if they are from the workforce. And the third is the normalization. I remember one of the quotes from the late 19th century, where the normalization was so much that if the women was not having pain associated with their menses, it was considered abnormal. So that is the level of normalization that has happened. Of course, we have improved, but it is a long way to go. And I think the right amount of education and awareness that needs to bring up. And like Dr. Floor mentioned, we need to educate. And as much as we can do as a medical community, plus the healthcare workers, we all have to come together and to bring a lot of awareness so that it's not a normalization and it should not be a normalization around it.
Mike, I wanted to look at you, but you just already great.
The important thing is just to normalize talking about it. I think, it just needs to be part of the culture and the fabric of how you look after the players on a day-to-day basis. And I think if you don't have that and you don't, haven't educated the coaches or the rest of the medical staff on how to or where to direct the players, I think you're going to struggle. And I think so that is definitely the first thing to do. So if players come to you, I think there's such a range of advice you can give players, and that's one of the, in a way, nice things about treating dysmenorrhea is that you can actually, there's loads of treatment options, and it can be everything from movement to TENS to hot water bottles to all the tablets and everything, and then obviously if things don't quite work out, you can also refer on. So there's a whole range of things that you can do for the players. I think actually just empowering them to understand and then make their own decisions. And I think if you created that culture amongst the team, that it's like if they have discomfort in any way, that they can come and see you. And obviously in our situation at Chelsea, we're very fortunate. I'm there most days of the week, so that if the players need something, they can come to me. So if So if you don't have that, you're only there 1 day a week as a doctor, then maybe supporting the rest of the medical team, whether it's the physios or the therapists, to direct the players. A lot of the medications are over the counter as well, so you can just get these things over the counter. So I think as long as the players are educated and empowered to raise it, they'll be better set to deal with it, and then hopefully improve their performance. Because at the end of the day, when you're working in our environment, the aim is to optimize performance where you can. And I think if the players are going into training or games in lots of discomfort, they're certainly not going to play to their best potential. So if you can normalize talking about it, I think you've probably got you've done half the job already.
May I ask you something, Mike, to that what you just mentioned? Thank you so much for the overview, Preeti. It was really nice. You say that you need to talk about it, and I completely agree. But what I see in the with the athletes themselves, they say, yeah, but when I talk about it, they will not put me in the team. So that's a disbalance in what happens when they go to me, for example, as a gynecologist. They are open and honest about what happens if they talk about it. So they want something that nobody has to know. So do you have a tip or something that we could do? Like, I assume you are not doing it, but there's so many more doctors and teams that maybe are handling like this. So can we help the teams or the athletes to be really open in this area?
Yeah, I mean, I think, if the players not playing because of it, I think would be a huge shame. And I think part of that would become sort of educating the wider team and sort of making them aware of like the things that there are plenty of things to be done to support the player and reduce their pain. And also, if they raise it sooner rather than when they're sort of been in pain for 1 to 2 days, they're likely to probably get on top of it a bit better. So I think that would be really not optimal that the players aren't playing or getting chosen to play because of that. And so I think there is probably a wider piece there in terms of the culture of the club and the medical team to try and improve. Obviously, if someone it can be quite crippling, the discomfort. And I think, in some cases, if you start to feel sick with the pain and you start to feel that you can't move, then playing obviously will be difficult in that situation. But that infrequently happens, and actually sort of mild to moderate discomfort is probably the most common presentation of primary dysmenorrhea, which is all very manageable if you can treat it and get on top of it early. I think if you have a culture whereby you don't, or you ignore it, or the players feel like they can't mention it and therefore they don't take anything or seek any advice, they're probably going to end up presenting maybe with more discomfort and then getting to a point where actually they're debilitated to play. And that, is very much not sort of a performance optimization sort of environment. So I think you need to, go back to the beginning and think, how do we address it? Because it is ultimately part of women's football or women's sport in general. And if you're unable to have an environment to deal with it, I think you're going to really struggle to help optimize the players' health and also their performance as a result.
Can I just dovetail one more question, Emmett? So on this one, I think, is there an unmet need to educate, the healthcare practitioners who are connected with the sports association as well as the board, and not only the players? I think it's beyond players. It's the management, where they really need to identify that this dysmenorrhea needs attention, but it doesn't mean it challenges the capability of the player. To Emma's point, that's right. If we bring more awareness, then there will be, okay, so you are during this, you're having, this specific period, you may not be able to perform, so you're not going to Olympics. I mean, just quoting one of the hypothetical examples. So I think there is an unmet need of awareness and education piece that really, really needs to be done, and how it should be executed, that it doesn't impact the players, you can say, career progression on that. So I think that's a very important piece. I don't know how it can be addressed, but is there anything that you can speak about it? Or is it something that you are already taking into consideration and they are paying some attention to that?
You kind of summed up the conclusion of this webinar there, I think, Preeti. That is definitely needed. And I would say also, given what I've heard in previous discussions and what Mike just answered, it is not just to the players. I think it's also to the medical staff, because it's already a barrier for players to talk about this, let alone for medical staff to talk about this with the player, and let alone for a male medical staff to talk about this with female players. So I think we also need to educate ourselves on how to do that. But Mike, is that a barrier you see in practice as well, opening that discussion? And you have some tips and tricks because you've been there.
Yeah, I think from a male working in the female game, you just have to be able to deal with it. And I think if you don't feel comfortable talking about it, you're probably working in the wrong environment, which is because it happens every day. And I think if you're not able to manage it, then no one else within the medical team is probably in a good position to do that. And you can't be referring all of these daily cases out to gynecology, because you wouldn't really get anywhere. You have a long list of players waiting to see the gynecologist. So. And most of them don't need to go to secondary care and to for referral. So I think it's just feeling comfortable about it. I think understanding the causes of it, being comfortable in taking a history, being comfortable in giving the medication out, being comfortable in giving advice about non-medication options. And then being comfortable when you recognise things, there are red flags, and you're looking at other causes. And I think that's the time when you're thinking maybe we need to go and look elsewhere for some extra support. But the majority of the cases I see are very much just straight down the line primary dysmenorrhea, which can be managed in house. And I think we infrequently refer out, and I think but so it happens every now and then. But majority of the cases are managed in house. So I think knowledge is power in this. I think if you understand the causes of it, and the medication and the options to support the players, then actually it's a relatively straightforward discussion, and the players almost become they know what to expect. I think if you have that environment, and I think if they will come to you very easily if they know that they're going to get the support they need. I think if they don't think that's there, they'll probably look elsewhere or not disclose it, which will subsequently have an impact on how they feel and the pain they get, and probably their performance as a result.
Thank you, Mike. Let's move to another topic, a bit on the clinical decision making. Betty, there's a big sign behind you. I just want to make sure that anyone who's listening in knows that this is not a sponsored webinar, but it's an NSAID, and you talked about NSAIDs in your talk as well as the first line of treatment. And timing and dosage seem critical, but what advice can you give players to ensure that they use NSAIDs in general effectively? That was for you, Patty.
Yes.
You were thinking.
Yes. Yeah, I think a bit I covered earlier, and to your point, I think Advil is the ibuprofen. So NSAIDs, what we have seen from the published literature, the thorough researches that has been done, and also from the clinicians' experiences as well, that ibuprofen and naproxen have been kind of the choice of, you can say, NSAIDs when you are managing or treating, you can say, primary dysmenorrhea. So we are talking about primary dysmenorrhea right now. And then also there are other molecules as well. As I mentioned, there are antispasmodics and others, but they may or may not be available over the counter. So when we think from the over the counter perspective, so there is a dose of 200 to 400 meg when we are talking about ibuprofen, which is very well established in OTC, and it should not go more than 1200 megs, or you can say the number of tablets that you're taking in a day. Similarly, when we talk about other NSAIDs like diclofenac is also, it can also be as an analgesic that can be taken, but it comes with this risk factor. So you have to evaluate and you have to balance which are even if you're taking up OTC analgesics, which are the ones which should be preferred. Similarly, when we talk about non-NSAID, paracetamol and paracetamol with caffeine, the dose has to be at least 4 hours interval in between. Duration is very important. And again, the dosage, for example, the combination of 500 meg with 65 meg of caffeine, which is like 1 cup or 1 shot of caffeine. So you're supposed to take not more than 1 to 2 tablets And again, the duration, like I mentioned, for anything with paracetamol, any molecule is 4 to 6 hourly primarily, unless and until there is a molecule which has a longer duration, which extends its duration in terms of its management. There is naproxen, which gives you the duration benefit, but then there is ibuprofen, which gives you a quicker onset of action benefit. So it depends which you're managing. You're managing a quicker action, or you're managing about the duration. So what is the kind of you can say underlying approach that needs to be taken when you're managing? Plus, I think I will pass on this question to Flor and Emma and Mike as well, in terms of how they have in their experiences been managing, and which have been their preferred molecules and why.
Can I quickly add something to that question, Emma and Flor, because there's also a question in the comments, and I want to expand it a little bit. When do you move from NSAIDs to potentially other medication?
Shall I answer this, Flor?
Yes, perfect.
Yeah.
You go.
Okay. I forgot to put down what I'm actually. I'm a gynaecologist also in the Netherlands, and I'm connected to the UEFA since last year. So the question is, when do you change from NSAIDs to hormones, or the other way around? Well, it really depends on the question of the athlete. So if you have, for example, a 14 or 15-year-old athlete with first year of periods, I usually start with painkillers, especially because most of persons think that hormones are bad, and they are a bit afraid for that. But as soon as they need contraceptives, it's a really easy talk, because then I say I make the conversation more to what do you want to get rid of, and most of the time it's the bleeding and the pain, and hormones will help you with both of them. And then if you have, for example, a breakthrough bleeding, or you have like a normal bleeding, then you can use the NSAIDs in between. So most of the time, the first choice is to start with the painkillers. We do naproxen and paracetamol combination therapy. And if contraceptives are needed, then we start with hormones. And then if there's no preference for one of these, then you just do the discussion. And I always ask the athletes to just track their period for at least 3 months. So I can see whatever happens in the bleeding days and also in the pain days, because not all athletes just have pain during their bleeding, but as Preeti already told, it can be up front of the bleeding, but it could also be happening during ovulation. And if you have this ovulation pain, for example, then it's even better to suppress your periods or your menstrual cycle with hormones. Otherwise, you're taking NSAIDs a whole cycle long. So it's a really discussion with the athlete and what they prefer.
There was a question in the chat about antispasmodic medication. Can you say anything about that, Flora, Emma?
I never give it. I don't. Do you have a name of a brand or something? Because antispasmodic, I never give it.
We'll wait for an answer in the chat on that one.
Like high-strength butyl bromide, so that is one of the antispasmodic. So I remember from Asia Pacific perspective, some experience. A lot of antispasmodics were used, and I think over the period of time, now not much. It's come back to the analgesics and anti-inflammatories, and the reasons have been either some of them have dipped in terms of their efficacy, or you talk about the benefit risk. Whenever we talk about molecules, we talk about benefit risk. So if the benefit is more than the risk, we continue with those molecules. But if there are more associated side effects, so those molecules take a back seat and the others come into the front line. So that's why perhaps like Emma and Flor mentioned, antispasmodics are not something that have been primarily been used, and it also depends on region to region. So you will see more of them in Asia Pacific as compared to Europe, as compared to US or Australia. So it really depends from the clinical practices and to what suits the patients, patient to patient variability, as well as how the molecules enter the market and are managed and registered and marketed in the market.
Thanks, Preeti. I didn't know that. And of course, I totally agree with Emma on what she said about when to switch from NSAIDs to hormones. And I think indeed, if you start NSAIDs and you don't have adequate pain relief, you need to switch. Or if you have a lot of side effects, that's not something we hear often. And another advantage of hormones is, of course, that you can regulate or even stop your periods. And that's what we see a lot with elite athletes, that they want to regulate their cycle. That's a lot. We see a lot of people because they have a big game and they want to regulate their cycle. So that's also another advantage of hormones, not only suppressing your cycle and have less pain and less blood loss, but also for the logistics about it.
And if I may add just one bullet to that, so I'm talking about the non-pharmacological treatments, so like Ayurvedic treatments or natural treatments, because I've been connected to that as well and had some experience in the clinical practice as well. We also have the phytoestrogens, which are known as the natural hormone therapy. So this is also another way. It can be with or without your current treatment regime that can be taken, which can help. Like Dr. Floor mentioned, to balance and optimize how you are managing your menstrual cycles in those days where you really need to pay attention or you want to be active in those days.
Thank you for that addition, Preeti. Mike, can based on all this information, can I have a look at you? How comfortable are you as a team doctor to navigate yourself across all these different medication advices, but maybe also make a little link to anti-doping concerns there?
Yeah, no, I think it's on the whole, I think that most of the medications will be used would be the sort of the pain relief medications, and if the player doesn't get it every cycle or doesn't find that the symptoms are particularly profound, the conversation usually sort of ends there and then in the first few days or towards the end of their cycle, of the beginning of their cycle, and it's usually 1 to 2 days of medications, if that. And I think if you can get on top of it early, you don't necessarily hear about it for another month. And I think if a player is then getting recurrent symptoms or particularly bad symptoms or symptoms that aren't settling with the medications you're providing, I guess you maybe sort of open up the options a little bit and then maybe looking to include contraception. I think obviously, as Emma mentioned, the conversation sometimes is very easy about contraception because if the player wants contraception and they have these symptoms, then it's relatively straightforward. I think if a player is unsure about contraception through various things they've heard or bad experiences previously, the conversation is a bit more challenging. And then I guess if you feel like the conversation is going to be relatively challenging, I think, and or there are other concerns for particularly severe symptoms, maybe you're thinking about referring out anyway and using your sort of specialist gynecology pathway and getting some extra support. But generally speaking, it's very common to be prescribing contraception, particularly tablets, in general practice. I think if you're looking at injections or coils, I think you're then looking for extra support externally, and it's not something that I would be doing. I wouldn't be putting coils in at the training ground. So those sort of things are you're looking externally, but yeah, on the whole, relatively comfortable with the contraception. It's just there is obviously a few more things to consider as well.
May I ask something extra, Eva, to Mike?
Yeah.
So do you have a good referral system, or do you know if most of the women's football doctors have a good referral system? If they have any short questions about hormones, or if they have any questions to dysmenorrhea, or do you immediately need to refer them? And if you need to refer them, do you know, have you specialists on this area?
Yeah, I think in London we're very blessed with a massive centre of top quality healthcare, lots with an interest in sport. So it's not too much of a challenge in London. I think if you were perhaps a bit more remote or weren't at sort of near centres of excellence, I think it would be a bit more challenging. I think you'd probably be relying on your local centre and developing some positive links there with the gynaecologist. And I think if you're working within women's team sport, I think it's pretty essential for you to have 1, 2, or 3 gynecologists in your phone because they will all have an interest in slightly different things. And so I think it's pretty essential that you have that set up. Otherwise, you're gonna struggle a little bit because you will have questions from time to time.
There was one more question in the comments, and there was a question I wanted to ask you, Mike, and maybe this is a question then for everybody that links to that comment. Let me see if I can find it. It's about data management policies. And my question, maybe a general question, was would we recommend routine screening or tracking of the menstrual cycle, menstrual pain in players? And if we do so, how should we do so in regards maybe also to data management here? Because this is, in the end, medical data that we have in our possession.
Yeah, I can start on that one. And so I think with regards to tracking, I think this is part of the sort of the cornerstone of empowering the players to understand their own cycle, when they're due on, when they might expect symptoms, what symptoms they can record. They can record a whole list of symptoms, and also the severity on a whole range of apps, which are invariably free. And then they can opt to share this information with you and the team and the people who then manage it. And so I think that the tracking bit, not only is it good for awareness of regularity of cycles, which is another topic, but it's also just good for their own understanding. And then they are able to appreciate, I can see I'm due to come on soon, so maybe I'll experience some symptoms, and then they can anticipate their own symptoms rather than it being perhaps a surprise if they're not as well adept to using calendar tracking. So I think from a team perspective, it's really a really useful tool, because it empowers the players. There's an opportunity to educate them on it, but also the medical staff can have access to it, and it's ultimately them consenting to sharing it with you. And I guess depending on what platform you're using, the data is invariably stored locally, and whether it's shared with you or not, it is part of the consent process during that. I think football players are a very trusting group of individuals. They share a whole host of private medical information with actually a huge range of people, whether that's an MRI scan about their ankle, whether it's their blood tests about their vitamin D, or whether it's their menstrual information. They actually share a vast amount of information. And so we do have to be very careful about what we do and don't share with them. And it's invariably a consent process with the player and asking them whether they're comfortable sharing or not.
That's a really helpful question, Mike. Thank you. General question to everybody, rounding this up. What is one misconception about menstrual pain you would like to dispel among coaches, performance staff, medical staff? Maybe I'll start with you, Floor.
I think I said it before. I think I think it's very important to know that dysmenorrhea should not be normal. I mean, maybe it is there, but then try to look for help to help our females.
You have another one, Emma?
Yes, I think that we can easily treat this. So with NSAIDs, painkillers, or with hormones. And I think you as an athlete should not walk around with pain.
Preeti? Oh, Mike unmutes. Mike, go.
Yeah, I would agree with those. I think ultimately this is a very manageable problem for the majority of females. And so there shouldn't be many situations at all where they're not been able to play because of it. So they should seek help and seek support for it as soon as they can, because the sooner they do that, the better the environment is. We should be able to manage it to very, very manageable symptoms so they can perform.
And Preeti?
For me, the misconception is that it's okay to have pain, so that normalization should be debunked. And the new normalization that should be introduced is about the education and awareness to embrace, to educate, and to manage.
Thank you. And thank you all for this very insightful discussion. We had a few questions. I think they're all answered. and we answered many more questions along the way. Thank you, Preeti, for your excellent presentation. And thank you, Mike, Emma, and Floor, for joining us to provide some further medical and on-field, on-the-pitch insights into this topic. Thanks. And before everybody logs off, I'd like to invite you to our next webinar, Monday, June 30th, pelvic floor health. The last one we have in the build-up to Women's Euro. We have Kari Bø from Norway, and we have Emma Brockwell from Ireland helping us through this very important topic. And you may have noticed maybe during this webinar that between the lines, we are working on some things on menstrual cycle tracking, menstrual health in players. And some of the people that were in our panel today are part of that process. And very soon we're gonna release a UEFA consensus on this topic. So we will keep you informed on that. But I think given today's discussion, a lot of questions that were raised today will be answered in the consensus as well. So thank you all. Have a nice morning, evening, or afternoon, wherever you are in the world, and see you on the June 30th.